Hello, everyone. I'm Dr. Carmen Pugliafito, and I'm here today with Dr. Veeral Sheth, who is from the University Retina and Macula Associates in Chicago, is also an assistant professor of clinical ophthalmology at the University of Illinois, Chicago Medical Center. So, Veeral, welcome back to Retina Synthesis.
Thanks, Carmen. It's great to be back.
So we're going to talk today about a new agent for gene therapy of neovascular AMD. And this is a novel approach. Why don't you tell us about it?
Yeah. So, I mean, you mentioned gene therapy. I think this is a hot topic in our field. And so recently I presented some data from the PRISM study. So the PRISM study was a phase 1/2 clinical trial looking at a molecule that we're calling 4D-150. This is a dual transgene intravitreal gene medicine in patients that we're looking at for wet AMD. And so a couple things that are a little different here, right? So this is a primate evolved retinotropic R100 capsid. So that's different because the actual vehicle is a little bit different. And then the what it's encoding for is a little different. So this is a dual transgene. So one of those transgene is for aflibercept, and the other is for an miRNA or like an interference RNA that inhibits intracellular expression of VEGF-C. So how do we give it? We give it through a single intravitreal injection. And then what we see is widespread delivery of this vector to all layers of the retina, and then efficient transduction, which is obviously the next key step, and then robust kind of pan-retinal transgene expression. So when we see that expression, what we're really seeing is inhibition of VEGF, VEGF-A, B, and C, and then PIGF. So some of that comes from the aflibercept side, and then obviously the additional anti-VEGF-C component to it.
So why do we call it a transgene?
I think it's because I think we're essentially gene transference. So I think it's really we're transferring these genes into the cellular material.
What were the results of the study?
Yeah. So okay, let's talk about it. It's a phase 1/2 clinical trial, like I was mentioning. So really, what are we looking at? We're looking at safety, tolerability, clinical activity. What I presented data on was the dose exploration phase. So we looked at 3 different doses, and just, I'll tell you, they're currently recruiting for the dose expansion phase. So we'll hopefully see that data in the near future as well. But the first part, dose exploration, we're looking at 3 different doses. We're looking at 3E10, 1E10, and 6E9. And if you are familiar with some of these gene studies going on, this is a lower dose than we're seeing in some of these other clinical trials with other companies. And I think it speaks to maybe the difference in the vector here. I think it also speaks to the fact that we've learned a lot in these previous studies, and perhaps too high of a dose, we're going to see safety concerns, inflammation, all these other things that we've talked about in the past. So the real question is with these doses, are we able to see, one, good safety, and then also are we starting to see some efficacy signals? And so in this trial, who were we looking at? Who were the patients we recruited into this study? These are patients that had some clinical response to an anti-VEGF in the prior 12 months, but they are also pretty high needs patients, right? So these are patients that had received at least 6 intravitreal injections within the last 12 months. And then what are the primary endpoints? We're looking at severity of treatment emergent AEs. We're looking at severe or SAEs. And then obviously secondary endpoints, looking at how many injections patients needed after getting the study drug, BCVA, CST, things like that. So what did we see? We saw, obviously most importantly, safety, right? So there were no dose limiting toxicities. We saw no 4D-150 related SAEs. There were 2 patients in the first cohort being the highest dose that we saw in one very small amount of pigmented anterior chamber cells. This is the first patient that received therapy. And then one patient that had mixed vitreous cell, just half plus. In that first patient that had pigmented cells, the patient was kept on topical steroids and did just fine. The second patient that had the mixed cells, they weren't done. Nothing new was done for them, no additional steroids. One thing I forgot to mention is that this study also, when the patient enrolled 7 days before they got the study drug, they got an aflibercept And one day before they got the study drug, they started a 20-week topical steroid taper, right? So that's important because I think we're starting to see a little bit more of that with the gene therapies. And with that, patients did extremely well. In other words, what I'm telling you is we had this one patient that had the pigment cells that did fine. And then the one that had the half plus vitreous cell, we didn't do anything different. We kept them on their taper and they did just fine. So, so we're very reassured by that data. And no white blood cells above 1+ in any of these eyes, no hypotony, no intraocular inflammation that required intervention, no retinal vasculitis, all the stuff that we think about now and that we worry about. We didn't see any of that in these patients. So again, that's kind of really the gist of my presentation. Now, the other thing I think that's really critical was, all right, so what did we see from an efficacy standpoint? Again, small numbers, but this is where we really kind of want to key in on, and especially because we're looking at different doses. So in that first cohort, which again was the 3E10 group, these were patients that before they got the study drug, again, required a high treatment burden. So they, on average, had 11 intravitreal injections of anti-VEGF therapy before getting the study drug. Afterwards, 4 out of the 5 in this cohort received 0 treatment after that. So in the 24 weeks following that injection of 4D-150, they required no supplemental therapy. So 4 out of the 5. That gives you basically what 80% of the patients didn't need treatment afterwards, and 84% reduction in annualized injection rate. So we saw that pattern in the lower doses as well. So cohorts 2 and 3, which were lower doses, we saw a significant reduction in the annualized injection rate, though we did see more of those patients needing supplemental therapy. So that first dose, the highest dose, did seem to do really well. That's a lot of info. Carmen, what else can I tell you about it? So I told you about safety. I told you about efficacy. What else
How
do you
many
want?
eyes were there in the study?
So there were 3 cohorts, 5 eyes in each cohort. So the cohort 1 that I was really kind of keying in on was 5 patients.
And it was a 1-year study?
It was 36 weeks. I presented data on 24 weeks.
So tell us about the steroid taper. What was that like?
Yeah, so patients started off with QID steroids 1 day prior to getting the study drug. It was prednisolone that they got. And then over the course of 20 weeks, kind of a slow taper. And as I mentioned, the patients, again, did incredibly well. And again, I think this is something you're seeing across the board with gene therapy, is that we've seen a couple cases, again, not in this study, in other programs, where we've seen lots of inflammation at higher doses. And I think we're just, being a little bit more proactive in the topicals, especially.
Why do you think this is better than the AAV2 or AAV4 delivery?
Yeah, well, listen, I don't know if I could say it's better yet, right? But I do think, look, I like the fact that you can achieve efficacy with a lower dose, a lower concentration of viral load, right? I think what we worry about is we're still trying to figure out the right mix, right? What's the right concentration that's going to get us the efficacy? I think ideally we want a one and done, right? I think when we talk to patients about this, we want to say, hey, we're going to give you something that's pretty safe and that will significantly reduce your treatment burden. And so I think we're still trying to figure out, where that sweet spot is. And so what I like about this is that so far we're seeing that sweet spot kind of play out.
Well, there's tremendous interest in intravitreal delivery of gene therapy. We have subretinal, we have suprachoroidal, both under very active clinical investigation. And we also have another manufacturer that has an intravitreal drug that has had significant inflammation through the study. So what's the next step for AD-150?
Yeah, so they're going to go to dose expansion, and so that's currently going on. So a significant, increase in the number of patients we're going to be looking at, and then look, we're going to see the end of the data from this first cohort. So 36 weeks out, we'll get some of that data. We'll see the dose expansion group, hopefully, if not later this year, next year maybe, and then see how it plays out. Look, what do we want to see? We want to see what kind of treatment burden reduction we're seeing. We want to see safety. The other thing we didn't talk about, Carmen, is this new MOA, right? we're seeing a couple things play out in the R&D space in retina. We're seeing people looking for better durability. We're seeing people look for different MOAs. And then this is one of those kind of places where all that meets, right? We're seeing through gene delivery, we're assuming that we're going to get better durability because of the incorporation of this material into the tissue, the cellular tissue. But also here, you mentioned some of the other things that are being tested. The difference here is we're not just looking at the traditional aflibercept kind of production. We're looking at also targeting VEGF-C, right? So whether that actually matters or not, we may start to see that play out in the data as well.
Well, there is some evidence that blockade of VEGF-C and D does improve the VEGF treatment algorithm. So
yeah, we're seeing that with some more traditional agents or traditional mechanisms like the Opthea drug, right?
Right.
I think it's probably what you're referring to. And I think, look, we've seen promising data that we can get even better vision results than with anti-VEGF alone.
Well, this is very promising. And we're just at the beginning of this story. So Veeral, thanks a lot for coming to Retina Synthesis and informing us about this really, I think, exciting development. Thank you.
Yeah, thank you for the opportunity, Carmen.